since it's kind of a long break. Anyway, so we talked some about arthritis already, and now we're going to talk more about artificial joints as well. As I said, arthritis is a broad term that has at least 102 different diseases that can classify as arthritis. Osteo is usually it's not simply overuse of a joint, but it's an overuse of a joint that is not stable. Usually not stable because of muscle weakness. And it may be overall muscle weakness, but it may be a muscle weakness on one side or the other of a joint. A sign of osteoarthritis is usually a creaking sound. Sometimes you get a popping sound as well when you move the joint pretty quickly. They believe the pop is due to the joint fluid accelerating and pulling the two bony ends pulling away from each other and causing a little nitrogen bubble maybe to form in the joint. People who pop their knuckles all the time and crack their necks all the time, the reason you get addicted to that is when the joint is accelerated repetitively, well actually even once, you get endorphins released in your spinal cord. And these bind to your opiate receptor. And so it's like you're in an opium den smoking opium. So people who pop their knuckles and pop their neck, I just tell them, you're a drug addict. You're addicted to your own drugs, which are your endorphins, but you're addicted to that. You can actually destabilize your joints if you pull on them enough. First sign in your fingers is the knuckles start to enlarge. And that's due to mild inflammation causing bone deposition on the edges of your joints. So your epiphyses enlarge, and you get enlarged knuckles. If it gets bad enough, your fingers aren't going to work as efficiently. Usually it's kind of a cosmetic thing and not a big deal. However, if you are a neck popper, let me warn you now. I give you this example, this young man that was in graduate school with me, he was a severe neck snapper. He'd be down the hall, 3 rooms away, and go, and I would hear him in my lab. And so, well, there goes Lance. And so one day he came in to visit me during break and I said, Lance, you've got to stop that. He goes, why? I said, well, first of all, you're destabilizing your joints. But second of all, think of how you're representing yourself to your future patients who come into your office and you're sitting there and you go, ka-tak, ka-tak. They're going to think you're an idiot. And they're going to get up and walk out, or they're going to politely wait and then never return. And it's not something you want to wait, you want to present yourself to your patients with. Good point. Well, I ran into him 10 years after that little mini lecture I gave him, and he ran up to me. He's already out of medical school. He's in his own practice, and he runs up, and he pointed to his neck like that. And so I looked, and there's this scar there, and said, you had a spinal fusion. He goes, you warned me, and I stopped, I stopped, but it was too late. So he had destabilized his cervical vertebrae enough that he started to get numbness and tingling and motor weakness in his hands. So he was damaging his brachial plexus. So if you're a neck popper now, stop. Yes?
I have a question. When I walk upstairs, my ankle pops a lot. It's not something like I do on purpose. I'm just walking and I hear it all the time. Like sometimes when I'm just walking.
Sometimes people have joints that when they're moving, they accelerate and they get that popping sound. If it's doing it with normal pressure, it's not so bad. It is a sign that maybe there's some instability there. Maybe you want to work on muscle strengthening for your ankle. Maybe it's an internal design that won't be corrected by muscle strengthening, but muscle strengthening does help, and it will stabilize the joint. Okay, hold on just a minute. Sometimes it's a disease process that is causing it. I had a student in my exercise classes who had rheumatoid arthritis and it affected her feet. And every time she walked, her toes would go katak, 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 katak. So in exercise class, there's this constant popping. So it could be a disease, but I kind of doubt it if it's one ankle and it's just limited to one ankle. But anytime you have instability, the first thing you're supposed to do is stabilize it. How do you stabilize it? Muscle strength. Okay.
Just wondering when a chiropractor cracks your neck, you know what I mean? Is there like a small amount of joint damage that's being done or anything like that?
So if my view based on the students that were coming to my class who were also going to chiropractors, the old-time chiropractors, not the newer ones, the old-time chiropractors used to say, just come to me, I'll adjust you, and you'll be fine. And the students are coming to me for exercise because it was fun and it was a group setting, and the chiropractor wasn't referring them to me for exercise. What I saw with these students, that they were getting worse and worse. Their symptoms were getting worse and worse. And so when I got to know them well enough, I said, you know, you need to see a chiropractor less and focus more on muscle strengthening because you're getting worse. And then they would say to me, you're right, I am getting worse. I didn't put it together, it was the manipulation. But chiropractic, nowadays, the chiropractors will do the manipulation, but they will refer you to physical therapy. They'll say, I can set your joints in alignment, but then it's your responsibility to keep them aligned. The only way you're going to keep them aligned is go and get the muscles strong. So there's a different point of view. The old timers used to say, you know, the manipulation is what you need, but with repetitive manipulation, the ligaments and the tendons get stretched out of shape and the joint becomes less stable, and then you get more symptoms. So I would not say don't go to a chiropractor, just choose your chiropractor wisely. If he says come to me for a manipulation, say, okay, see you later, and find another chiropractor who will refer to exercise programs.
You talked about like popping your neck and knuckles, but what about like your back?
Well, yeah, some people do that too. They go whack, whack. And it's the same thing. You have a bigger, more massive lumbar vertebrae. You have a smaller, more fragile cervical vertebrae. So the lumbar region is much harder to get going through a large range. The neck is much more easily put through a large range. Generally, you can use gravity to snap your neck, gravity and acceleration. And so it's at those extremes of the range where gravity has the greatest effect that the opposite side has the greatest impact and instability. It's harder to do that with your back. But if you do it enough with your back, you probably will also need fusion in the low back as well. The fusion is done by taking bone from your hip. So you got to go into your hip and get bone, and then you got to go into the neck and you got to put it there. You got 2 surgeries to deal with. So it's just a pretty big, payout for simply doing something and not really understanding the consequences of it.
So is it better not to stretch then?
I'm not saying don't stretch. I'm saying don't stretch violently. Don't use acceleration and gravity to go to the end of the range and then boing, you come out of it. We'll talk about stretch receptors, and when you do the accelerated kind of, the ballistic kind of stretching, which neck snapping and low back snapping is, you also make the muscles tighter and you make the brain sense that tightness and it says snap more. So there's a double whammy. The muscles get tight, but also you're addicted to your endorphins and get the buzz, and the brain says, like that. The stiffness, if you're doing ballistic stretching, the intrafusal fibers, the stretch receptors, will get set at a lower threshold. So any tightness, any stretching of tight muscles now sets off more muscle contraction, which makes the muscles get tighter. So stretching using, that's a ballistic stretch. Okay, so bouncing kind of stretch. So if you're bouncing side to side or bouncing your head side to side, as opposed to just letting gravity stretch you out and slowly stretching. You might get a pop with a slow stretch, but it's because the muscles finally are letting go, and then the joint accelerates, and so you get a pop, you get that nitrogen bubble. But if you're doing it infrequently, you don't get that endorphin addiction, so you don't desire it as much. When you do a slow stretch, the stretch receptors, those intrafusal fibers, actually set their threshold higher, so they don't fire as often and don't cause the extrafusal fibers to stay as tight in the resting position. So you can use your intrafusal fibers, stretch them, reset them so that your muscles will relax. And partly with muscle strength, more stability, less irritation of the muscle with minor shifts in posture, the better your muscle will be at stabilizing the joint and not erroneously firing and creating tension. So hard to do when you have joint pain, but you can do it. The ballistic stretch will make the situation worse. So you encourage your clients, and I did my students, to do the slow stretching and within their pain tolerance, because if you go into the stretch slowly, then it might be uncomfortable, but as long as you don't push, it should not be painful. And over time, and along with muscle strengthening, the range of motion will improve. If the hyaline cartilage degenerates on the surface of the bones, first thing that happens during osteoarthritis is there are collagenases, elastases, and proteases released in this disease, as well as rheumatoid. That softens the articular cartilage, and then with the use, it roughens up, and you get a creaking sound. So if you're creaking and not popping, it may be crepitus. It may be that at one time you damaged the joint and the cartilage is now softened, so it's creaking. But if it's like a sound, popping sound, then that's probably nitrogen bubbles and just joint acceleration. So when it sounds like sandpaper or like Snap, Crackle, Pop, Rice Krispies, that is crepitus. And crepitus is not arthritis yet, but it's a sign that the joint is unstable and that the cartilage is softening. And if it continues to soften, it may start to fragment and then expose bone, and then you might lose the function of that joint. It's certainly when the crepitus is there, it's harder to move the joint. It's usually inflamed as well. So sounds of crackling and crepitus get the muscle strong, and the sound will get less. I was a swimmer. From 7 years of age into college, all I did was swim. And I got real tired of smelling like chlorine and being green sometimes and just sweat all the time, morning, afternoon. I'm tired of this. Decided I wanted to run. what an idiot. I was designed for swimming, but I decided I'm going to run. And I didn't know how to teach myself how to run, so I jogged until I got tired, and then I walked, and I built up my stamina. I was able to run 2 marathons. At the end of the second marathon, I was coming to work one day, and I was having a hard time getting up the stairs. There was about 20 stairs. And I heard my knees going. My partner inside, she said, was that you coming up the stairs? You could hear me through the entry hall into the office. She goes, yep. I thought, okay, I have to reevaluate this. So I stopped running. I thought, well, by the time I'm 40, I'll probably be in a wheelchair if I continue doing this. Don't want to be in a wheelchair. Let's stop running. So I did. Went back to swimming, found ballet, and I thought, well, maybe ballet's bad, but it actually was very good to train the quadriceps, because you're not grand pliés or anything, but just the tendus and all the footwork really worked those quadriceps. And I noticed that my crepitus was quieter. Now, when I extend my knee, I can feel that the crepitus is still there, but you can't hear me extending my knee, so it's improved. So it can go away, the audible can go away, but it's going to be there for a while. Bone spurs are like little rose thorns. They actually look kind of like little rose thorns. When the joint becomes unstable, and maybe there's some bone density issues, the body tries to repair and deposit more calcium into the bone, but it doesn't get it into the bone where the osteoporosis is. It puts it on the edges, and so it builds up the cortical bone. And the cortical bone starts to form these little bone spurs or little sharp projections. And when you bend the joint and they press into soft tissue with nerves in it, it's very painful. So if the bone spurs actually go across the joint and meet up, then your joint is fused and you can't move it. But before they fuse, every time you move them and they press into soft nerves, it's quite painful. Rheumatoid arthritis, again, autoimmune attack, more on the tissues, but the tissues of the joint are oftentimes very quickly degraded. The synovial fluid will change in consistency. It also changes in osteoarthritis as well, but usually not as fast and not as extreme. Some signs of osteoarthritis where the synovial fluid has been altered is you wake up in the morning and your joints are kind of stiff, but you go into a warm shower and the warmth loosens, it causes the molecules in your synovial fluid to move more quickly, and so the fluid becomes more fluid. The synovial, the consistency of the synovial fluid becomes more like it used to be, decreasing joint forces and easing the freedom of movement. So it actually becomes more gelatinous overnight. The muscles aren't working, they're not generating heat, not keeping the synovial fluid warm, so it congeals. And then either exercising a little bit or going into a warm shower or putting your hands in warm water, that helps to warm up the synovial fluid, and then it's more watery again. Rheumatoid arthritis will have remissions. Women who are pregnant, the rheumatoid arthritis goes into remission. I had one student who said, I had 10 children because I loved being pregnant, because I had no symptoms of rheumatoid arthritis when I was pregnant. Of course, being pregnant 10 times took a toll on her joints, but she was symptom-free while she was pregnant. And then after the 10th child, I guess she figured out, well, maybe having any more children, I'm going to have more problems with my joints, so she kind of stopped that. But they can have spontaneous remission. The remission can last for years. It can last for a couple months. It just varies from individual to individual. Steroids are a common treatment for the inflammation. Non-steroidal anti-inflammatories more often used in osteoarthritis. So something like naproxen, ibuprofen, aspirin used to be used a lot. It's a very good non-steroidal anti-inflammatory. But if you use it in high doses, you get ringing in your ears, you have blood clotting problems. So they invented these other types of non-steroidal anti-inflammatories. For rheumatoid arthritis, often still high doses of prednisone and corticosteroids. Aspirin used there as well, but now they have other medications, a lot of different medications. You can't even keep up now. The drug companies are coming out with new medication. If you listen on the TV to the side effects, like, why would you want to take that? It just goes on. It helps your rheumatoid arthritis, and then the rest of the ad is about all the side effects that occur, and heart disease, and anyway. So the idea to protect the joints is reduce the inflammation. When you examine a joint, you remember your ABCs. So alignment, are the bones subluxed? Are they dislocated? Or are they aligned properly? Cervical subluxation, you can Google that and you'll see that the whole head is off to the side here. It's like a stair step on the neck is just moved to one side or the other. So you can have cervical subluxation. We saw the subluxation in the hands. You can have also subluxation of the wrist. The wrist is supposed to be at 180 degrees when you have co-activation of your extensors and your flexors. When the person tries to maintain that and they have subluxation, you'll see a stair step down. So the metacarpals are usually below the radius and the ulna. Dominant muscle group always predominates when there's joint instability, and that will be your flexors. So the wrist will be pulled down, and your fingers will be pulled out. You look for bone density, can take a simple x-ray, and you can, if the bone density is severely compromised, it will show up on an x-ray. So by the time you see it on an x-ray, you really have lost a lot of density. So you probably want to do, if you have a disease like rheumatoid arthritis, you probably want to do a bone density test as opposed to just using x-ray, because that is more sensitive. It also uses lower doses of x-ray, and it will show up osteopenia, whereas probably only osteoporosis is going to show up on an x-ray. But simple, if you see it on an x-ray, you better do something right now. Normal bone density will show up as creamy white. When it starts to look blacker, you've got problems with bone density due to erosion. And the erosion can be on the edges, it can be inside. You can have bone loss just in one area that's focal, and it could be widespread. And then spurring is usually you're going to have erosion somewhere, and the body is trying to correct for the erosion, but it ends up depositing bone on the edges. I went to a conference when I was in grad school and kind of timid. There's a lady talking about a new medication she was working on in the lab, and this medication was going to increase bone density in people with osteo and rheumatoid arthritis. Not being brave as a grad student, I waited till after and I asked her, how are you targeting the calcium to the osteoporotic bone that's inside. And she said, what do you mean? I said, well, in rheumatoid and osteoarthritis, the erosion is internal. The cortical bone is becoming less dense. And the body's attempt to correct it is to apply bone to the outside. So the cortical bone gets denser, but bone spurs form. She says, what's a bone spur? At that point I thought, oh my God, why are you doing this research and you don't even know your basic anatomy? You don't know your pathology. You could be inventing a drug that's just going to make spurs happen faster. You don't even know that where you're supposed to target the calcium. So I just said, well, I think you need to find somebody who can explain these things to you and then work with you so that you find out how you should manipulate your medication. So far, I've never heard of a medication that actually gets the calcium inside the bones, so I don't think her medication came on the market. If it did, it just made the situation worse. The other thing is you look at the joint space, that black space between the bones, that actually is where your articular cartilage is. If it's nice and evenly distributed, this black space, then you probably have normal articular cartilage. If the creamy white is coming closer together than it should be, that means you have erosion of the cartilage. If it's closer on one side than the other, that means you have focal erosion of the cartilage. And you usually can see that when you have, you ask them to straighten their joint and it's out of alignment. The most severe example of erosion of the joint space is when the femoral head goes through the acetabula and into the pelvis. That is called protrusio acetabuli. So the head of the femur is protruding through the acetabulum and into the pelvic region. That joint is not functioning anymore. That person cannot ambulate on that joint. It can't move. They can't probably even tolerate weight bearing on that joint. But the acetabulum, the tissues wore out, and then the femoral head just went right on through. Synovial fluid, I mentioned it should not be opaque. That is a sign that inflammation is occurring. If you take the synovial fluid and you look at it under the microscope, you can count the number of white blood cells in the synovial fluid. Normal, you see about 500 white blood cells in the synovial fluid. When the synovial fluid is opaque, you're up around 2,000, so 4 times more than normal. Those white blood cells are releasing the enzymes that are breaking down the proteins in the synovial fluid. They're denaturing the protein. It's sort of like adding acid to your fish, and it looks like you're cooking the fish, but you're just denaturing the protein, or putting acid onto the egg white, or heating up the egg white and denaturing the protein. The proteins turn opaque when they unwind. So the opacity of the synovial fluid going from a clear yellow to a white is due to the denaturing of the proteins in that fluid. Okay, so just another picture, more subluxation. What you see on the outside, these really gnarly, enlarged knuckles of rheumatoid arthritis. So next week we'll finish on arthroplasty.